Okay, this lecture will be covering patient assessment. You have some objectives: state, list, demonstrate, find, and measure and record. And we are actually going to be doing that in lab, which is good. So you guys will get some hands-on with this also. So key terms also, so make sure you're able to identify the key terms. So essential skills of patient assessment, there's observation, evaluation, assessment, and communication. So you're relying on information in order to be able to properly assess the patient. So those of you at certain facilities go by the acronym of AIDIT. It's a communication tool, and each letter stands for something. So the A stands for acknowledge, I introduce, D duration, E explanation, and T thanking the patient for coming in. Okay, when you take a history, there's questioning techniques that you should be aware of. You're always going to want to ask open-ended questions. You're going to want to realize that the patient's being silent and guiding them, so facilitating them through the process in a way that is structured so that you can get your information that you need. So there's also reflection, there's clarification or probing. So the biggest thing is communication. So when the patient tells you something, that you repeat it back to the patient. I understand that you stated that you've had pain for 2 weeks in your right lower quadrant. Is this correct? So you always want to make sure. Did you say that you had pain for 2 weeks, or was it 2 days? How long is a while? Is it a week, a month, a year? So always ask for more clarification when you can, and then summarize it all. So you're here today for an exam, looking at your abdomen. You've had pain for 2 weeks in your right lower quadrant. So that's how I handle all my histories, to make sure that I'm getting the correct history. All right, elements of a history. We want to know onset. When did it start? How long has it been going on? Is there a specific location? Can you point to it? Can you show me? Is there a spot that there's a lump? Anytime there's a lump, we usually put a marker on it so that we can show the doctor exactly where it's at. The quality of the symptoms. Is it sharp? Is it dull? How on a pain scale? Is it just a low level pain that's just there all the time? Is it a severe, sharp, stabbing pain that's intermittent? Or is it there all the time? So is there anything that makes it better or worse? And what other things are happening with this? So if you have the sharp pain, does it come along with also vomiting? So those are the kind of things that you're going to want to ask the patient. You really want to find out what's going on. So some of the questions is, how did it start? What happened? When did it first trouble you? Was it sudden or a complaint that gradually got worse over time? Or is it just after you eat ice cream? So you hear that one on gallstones or fatty foods. Okay. So have you ever experienced this before? Yes, 5 years ago. No, I've had surgery for it. It's been fixed ever since, and now it's back. Has it been continuous, or is it intermittent? Does it bother you all the time, or is it just sporadic, or is it just after ice cream? How long has this attack been bothering you? So you want to make sure you get a time frame and ask the open-ended questions so that they have to give you information back. All right, so where does it hurt, and or where is the problem? So they'll point exactly where it's at, or they'll say it's on my back, I can't reach it. Can you feel exactly where it's at? Can you put your finger where it hurts the most? Does it hurt anywhere else? So if they have an ankle fracture, you can say, okay, on your ankle, I understand, you broke it, you're in a cast. Is there any other place that's hurting you? So there are times that we miss other fractures because we're so focused on the one pathology. Okay, what does it feel like? Sharp, stabbing, dull, throbbing? Throbbing is one. Does it pulsate? Can you feel your heartbeat in it? So sample questions. How severe is it? Mild, moderate? Pain scale 1 to 5, 1 to 10. 0 is no pain. 10 is the worst pain you've ever felt in your life. Does it wake you up at night? Those are great questions. What seems to make it worse? When is it the worst? Is it worse in the morning? Is it worse at night? Is it worse after you eat? And And does it hurt when you walk, or does it inhibit any of your daily duties that you do? Okay, so what has helped it in the past? So have you taken pain meds? Has that helped? Did you take an antacid? Does that help? Does that still help? So sometimes they're like, yeah, I used to be able to take an antacid, and now it doesn't work anymore. I'm still having this, burning in my chest. So what do you do now that seems to help? Well, I cut dairy out, or I stopped eating gluten, and it seems to have helped a lot. So you're going to want to ask these questions. Does the time of day, so the amount of rest or change in position, make any difference? So if it's an ankle fracture at the end of the day, it's probably the most swollen and the most painful, whereas first thing in the morning, it may be really hard to walk on it, but it doesn't hurt like it does at the end of the day. So those are really, really key questions that you're going to want to get the answers to for your radiologist. All right. So, are there any other symptoms that you're experiencing that are associated with your chief complaint? So, the chief complaint is the reason why they're there. So, ankle fracture. So, is there any other symptoms that you're experiencing that are associated? Yeah, I broke my right ankle, but now my left leg and hip have been hurting me, or my back hurts now. It's because they're walking funny. But, you're going to want to know that. All right, so assessing the current physical status, you're always going to want to check the chart, and that'll give you more specific information that you'll need for the patient. Physical assessment, it's an ongoing process of observation, comparison, and measurement of the patient's condition before, during, and after imaging procedures. And vital signs, so that's temperature, pulse rate, respiratory, and blood pressure. So we have medical alert bracelets that typically the patients are given. Now, they don't always have these bracelets on. It's really important, though, if they have them, that you pay attention to it. So if they're a DNR and they code with you, typically in radiology, we still hit the code and have them come, and then they just process the patient, which is really nice. And then if they have any allergies. So it's really important to take a look at that, especially if you're in CT or if you're in MRI and you're going to be giving them contrast. You need to know if they're allergic to your contrast. You'll have an allergy bracelet on, or if they're allergic to latex, like I am. You're going to want to know so that you do not touch that patient with anything that could possibly cause them to have a full reaction. And then fall risk, that is the most important. I know in the hospitals, it seems like they put this fall risk on everybody. It's like they walk through the door, literally walk through the door, and they put a fall risk bracelet on them. It's like, oh my goodness. So you have to pay attention to that fall risk. If the patient falls in your care and you have them up and walking and they're a fall risk, you're in a lot of trouble. All right. So physical assessment. So we look at skin color and temperature. We look for cyanosis, which is the bluing of the lips, nail bed, and the mouth. So around the lips, you're going to see a bluish tint. And in the nail beds, you'll see a bluish tint. So my daughter has asthma that is this very strange asthma. She doesn't wheeze. She just turns blue. So I've seen this around her lips, and I'll check her nail beds. So as she grew up, so we're racing to the ER at 3 o'clock in the morning, and because she's blue. So not fun, but not everybody wheezes. So if you think, only, will they be blue because of, asthma where they're wheezing? Not everybody wheezes. They just turn blue. So take a look at the lips and the nail beds. So look at their level of consciousness. So LOC. Are they alert and conscious? Are they drowsy but responsive? Are they unconscious but reactive to pain stimuli? Are they comatose, so they're not responsive at all? And the breathing, is it quiet and calm? Is it rapid and shallow? Are they wheezing, coughing, or gasping? So when you get a patient into your room and you are responsible for this patient, you should kind of take a look at your patient and see how they are, because there are times where I've done an x-ray and I've come back and the patient looks very different. An MRI, when I pull them out of the bore, I'll take a look at the patient. I'm like, uh-oh, so make sure you take a look at the patient, because they're going to ask you, was the patient like that when you got them? And you can say, no, they were not. Or yeah, they were a little blue and they were having this really shallow breathing and they're gasping. So you're going to want to know that. So if your patient does change, you're able to react. Okay, temperature. So there's different ways to take a temperature. And the normal body temperature is 96.8 through 99.8. And the rectal range can be half to 1 degree higher, and the axillary can be a half to 1 degree lower. So typically patients are the lowest in the morning. Just so you know, there can be a swing in the temperature. My temperature typically is around 94 to 96, and I'm freezing all the time, and that would be why. I never understood it until I actually went to school to be a CNA. I'm like, oh, that's why I'm always cold. My temperature, I need to get my temperature up. All right, so there's the easiest way to do them is the external ear canal. All right, so there's the temporal artery thermometer. So you use its infrared sensor and it measures over the temporal artery in the forehead, easy and quick. Patients don't mind it and is the most accurate. So that's good. The most people are going to this new temporal thermometer. Okay, so on pulses, as you can see here, we've got the temporal, the carotid, the apical, the femoral. Popliteal is on the back of the knee. You have the dorsalis pedis and your posterior tibialis. You have your radial and your brachial. So the most common is for you to do the radial pulse. If you can't feel a radial pulse and you're gravely concerned about your patient, you can jump up to your carotid pulse. We don't like to do that because you can actually stimulate and lower their blood pressure. So you don't want to do that. The femoral pulse is a good one because the artery is actually the most superficial. Normally veins are superficial, but in the femoral, the artery is superficial, so it's easier to feel. All right, so the average is 60 to 100 beats per minute, measured in beats per minute. Tachycardia is when the heart rate is going too fast, so it's over 100 beats per minute, and bradycardia is when the heart rate is below 60 beats per minute. So a lot of athletes and triathletes will be below the 60. They'll run around 40, 50, under 60 typically. That is not uncommon, so don't freak out. All right, respirations. Count the number of breaths per minute. So the normal range is 12 to 20. Fewer than 12 breaths per minute is bradypnea, and tachypnea is greater than 20. Whoops, going the wrong way. So blood pressure is measured with the sphygmomanometer. Say that one fast 10 times. Okay, it's expressed as your systolic diastolic, and your systolic range is 95 to 119. Your diastolic is 60 to 79. That is your normal range. So hypertension or high blood pressure, there's two stages. The first stage, your systolic range is 140 to 159, and your diastolic is 90 to 99. Stage 2 is the most severe, so that's a systolic reading of 160 or greater than, and your diastolic is 100 or higher. So that patient is in severe trouble. So you need to get their blood pressure down quickly, okay, especially for the stage 2. And hypotension is your diastolic pressure. I don't know why they have this backwards, but your systolic pressure is less than 90 and your diastolic is less than 50. Your common laboratory tests for patient assessment, you have your CBC, which runs 12 different determinations. We can find out a lot from a CBC. We have the electrocyte sediment rate, which determines the presence and or extent of infectious conditions and inflammatory processes. So, and those are usually patients that aren't having any symptoms. So we'll look at the sediment rate. There's blood clotting assessments, which is your PT and PTT. So your heparin, EXA and your D-dimer. So you'll hear those. We'll always ask before we do a biopsy, what's the PT and PTT and the D-dimer if needed. And then your blood chemistry test. So you have your glucose, cholesterol, BUN, creatinine, and serum bilirubin. So for kidneys, since we are in radiology and we're doing laboratory tests and we're checking to see if the kidney function is good, we're always going to look at the creatinine. And the creatinine is the main thing for your EGFR calculators. And your BUN will let you know if the patient's dehydrated or not, and for part of the cause as to why their creatinine is high. All right, so electronic patient monitoring. There's a pulse ox, so it's placed usually on the finger or toe. You can put it on the earlobe. Also, in MRI, I'd always remove those. I didn't trust the wires that they wouldn't burn the patient. So it continuously monitors both pulse rate and blood oxygen levels. So it measures pulse and oxygen levels. So the range for your oxygen level is 95 to 100%. If the patient drops below 95%, you need to see about putting the patient on oxygen as a supplemental. So an arterial catheter is a comprehensive way to monitor cardiac activity. It provides continuous measurement of heart rate and blood pressure at the same time. You need to be careful with these patients and not bend their legs. All right, electronic patient monitoring. So electrocardiograph. So it's a device that measures the electrical activity of the heart, displays the information graphically in the form of waves on a paper, tracing, or on a monitor. So a graph is called an electrocardiogram. So the ECG or EKG. That's probably how you know it, right? So when we look at a normal EKG, so we come in, we have here coming in, and then this is our PR interval. So we have our P, which is atrial depolarization coming down, and then we have our Q, we come up, R, S, so we call it the QRS, and this is where the ventricular depolarization happens. And then you have your QT interval. So the QT interval, you're going to hear him talk about that quite a bit. You'll hear, oh, there's an elongation of the QT interval. So if you're in cardiac cath lab, you're going to know all of this, okay? So this is the beating of the heart right here, and then it's repolarizing. So the ventricle repolarization. So we're going to look at the PR interval and the QT interval to check and see if the patients have any issues. Okay, so we talk about sinus brady. So brady means slowing. So this is a sinus rhythm. A normal sinus rhythm would be another one in between each one of these. So there'd be here. So it's beating very slow. So you can see your PQRS and your T wave there. And then you can see your sinus brady. You can see how fast the heart is beating over and over and over and over and over. So it's going to get tired. So we don't want them to beat too slow, and we don't want them to beat too fast. So looking here at all the different arrhythmias, sinus tachycardia, you can see how fast this heart's beating. Sinus bradycardia, atrial fib, so you can see in between, it's just kind of just bouncing there and not giving a normal contraction. And this is sinus VTach. There's all these different ones. So second degree heart block. You can see the intervals between, and there's no pulse there. So there's no beating of the heart. So this is fine VFib, so ventricle fibrillation. So fibrillation is where the heart just shakes. It doesn't actually beat, so it just shakes. Here's coarse VFib right here, ventricle fibrillation, and atrial fib. So you can see it's just fluttering. The heart's just shaking. All right, then we have electroencephalography. So it's used to record and monitor the electrical activity of the brain. So they put all of this on the head of a person who's had a stroke or something going on, this brain injury or something, and it monitors all the waves activities of the brain. That is your patient assessment lecture. I hope you enjoyed it.